Good morning, everyone. Thanks for inviting me here to talk today. I'm happy to be here to give some updates on pulmonary medicine. Okay, good. So no relevant disclosures. So my talk today is going to be divided into two parts. The first part, I'm going to talk about the updated ATS ERS guidelines for pulmonary function testing. You know, pulmonary function testing is a test that I'm sure everyone in this room has ordered at some point before, and there's new interpretation guidelines that may make you kind of think differently about how you interpret the results that we ultimately provide on our reports. And the second half of my talk, I'm going to transition to giving an overview of interstitial lung disease. Mostly I chose this topic because interstitial lung disease is pretty obscure topic. I feel like most people in residency will get some exposure on rotations of pulmonary clinic, and then afterwards there's not much thought besides necessarily referring the patients to pulmonary. So want to give you a brief overview and then transition to the new concept of interstitial lung abnormalities that it may have more relevance in the future, especially as we are obtaining CT scans on a more regular basis. So to start, pulmonary function testing, again, this is a test that everyone here orders fairly regularly. We get it to explain why patients are short of breath or dyspneic. We use this test to help diagnose different lung diseases, and in pulmonary clinic, as we see these patients over the years, we use PFTs to monitor the disease progression and kind of how patients are responding to the treatments that we provide. So here at Scripps, we're happy to have a very robust PFT lab. Our respiratory therapists are excellent. We pretty much have all available tests that you can want to order. So that includes a spirometry, the very basic assessment for airflow. We obviously have the bronchodilator response where we provide either albuterol or levalbuterol. We have the body box for lung volumes, diffusion capacity, exhaled nitric oxide to get an assessment of airway inflammation. This can be helpful in diagnosis and monitoring your patients with asthma. We can look at respiratory muscle strength, look for neuromuscular weakness. We have our methacholine challenge, which is a very sensitive test for diagnosis of airway hyperresponsiveness. And then we also have our exercise studies, including our 6-minute walk test, hallway exercise oximetry, decide if patients would benefit from supplemental oxygen, and our cardiopulmonary exercise test. This test can be somewhat difficult to interpret, but we often use it for patients to screen for chronic thromboembolic pulmonary hypertension, post-pulmonary embolism, or to assess for what the underlying cause of dyspnea is when you're just really not sure with all of the other studies that you would typically check. Steps for pulmonary function testing or interpretation: we first assess whether the values are within the normal range expected in a healthy population, and then we try to identify the physiology, whether it's a more restrictive or obstructive pattern. If available, we try to assess pulmonary function values over time to, again, monitor response to treatment or monitor disease progression. And finally, we ultimately try to use the physiology data from pulmonary function testing combined with all of our other clinical data that we have with patients, including imaging and your history and physical, and ultimately come up with a differential diagnosis and management plan. So to begin, I have one audience response question. So this question: a change in which of the following defines a positive bronchodilator response? Is it either FEV1 or FVC greater than 10% of predicted value? Is it FEV1 over 12% of measured value and 200 milliliters? Choice C is either FEV1 or FVC greater than 12% of predicted value. And final option, either FEV1 or FVC greater than 12% of measured value and 200 milliliters. So I'll stop for 30 seconds and see what you guys think. All right. Sorry, are we able to see the response? Wait, go back. Oh, okay. Oh, okay. Um, let's go. So, okay. So the answer is actually choice A. I'm not able to see what everyone chose, but choice D was actually the correct answer based on the 2005 ATS criteria, so over 12% and 200 milliliter improvement in either the FEV1 or FVC from baseline measurement. The answer for the 2022 guidelines is a 10% increase in predicted value of either the FEV1 or FVC. So I'm not sure, what the distribution was, but this is one of the many changes that we will see in how we read pulmonary function testing. And for this response in general, in terms of the patient's baseline value, if a patient has a fairly low FEV1 to begin with, the thought is it's much easier for them to reach a 12% increase. And so instead of using the measured value as the baseline predictor for the percentage, you use what their predicted value is supposed to be, and you use 10% instead as a cutoff. So that's the argument for the change in the new criteria. So again, this is a title page for the updated guidelines. We'll talk about spirometry. We'll focus mostly on spirometry, but we'll also talk about lung volumes and diffusion capacity. This table, busy slide here, but this table provides a summary of the changes from 2005 to 2022. Good slide to just reference at some points if you ever have questions about interpreting your pulmonary function testing results. The biggest take-home point, though, that I want to highlight is that there's an emphasis on using our pulmonary function testing to classify a patient's physiology and not necessarily to make a clinical diagnosis. So when we read the pulmonary function results, we're essentially seeing a snapshot of a patient's performance at just one moment in time, similar to when radiology reads a CT scan. They're looking at one snapshot. They don't necessarily have the clinical history of the patient. We do our best to, again, interpret the physiology of the test result, and then ultimately, by providing that result to the ordering physician, it's up to the ordering physician to then use that data along with all the other clinical data that you have for the patient to come up with a differential diagnosis and treatment plan. So keeping this big picture in mind, let's take a look at the pulmonary function testing reports before the updated guidelines and then after. So this is a typical report that you'll see pre-2022. We have our flow volume loops. We take a look at the flow volume loops at the bottom first to just get a sense of what the values are potentially going to be. Usually, once you look at these enough, you kind of get a sense based on just the pictorial flow volume loops that the patient's going to have severe airway obstruction, restrictive pattern, or a normal spirometry. We subsequently assess the FEV1, FVC ratio to decide if there's airway obstruction. And as I'm sure you guys all know, we mostly used a set cutoff before at 7, but that's not how we do that anymore. Okay, this is the old methodology. And then finally, after assessing whether a patient has airway obstruction, we then look at the percent of reference, so percent predicted, to assign severity for the patient. 80% was kind of the old way of how we use the cutoffs, and that again is all changed as we'll see. Okay, so this is a new pulmonary function test report. Same test as the prior report from same patient, both normal results, but you'll see there's actually a lot more columns on this new report. We still have the absolute numbers on how the patient did in the pre-column. We still have the percent predicted, even though we're not supposed to use that for assigning severity anymore. The reason we still have the percent predicted is it's simply an intuitive way for both most clinicians and patients to kind of get a base sense of how their values stack up to the general population. And then you'll start seeing the new column. So we have the lower limits of normal, we have an upper limit of normal column, and we have a Z-score column, as well as a pictorial on where the patient's values are relative to the average for someone, their age and height. The steps to interpreting the pulmonary function is actually still the same. We still start by looking at the flow volume loops, getting a sense of the patient's physiology. Then we look at the FEV1 to FVC ratio, and again, decide whether this is more of a normal pattern, restrictive, or obstructive pattern. And then we are actually supposed to assign severity based on Z-score instead of the percent predicted. So that gets more complicated. I'll explain in the next few slides. Overall, these updated guidelines actually provide a much more accurate description of the patient's physiology, and I'll show that. I'll show you why that's the case, but the interpretation of the report that you get will require more nuance to apply the report to what you're going to do for the patient. So this is just some basic statistics. Okay, this is a normal distribution graph. The Z-score of 0 is basically the average person for whatever parameter you're measuring, the average for population. Z-score of -1 will be one standard deviation below. Z-score of +1 will be 1 standard deviation above the average. And per the guidelines, the limits of normal is now arbitrarily set at the 5th percentile, so the bottom 5th percentile, and the top 95th percentile. So essentially 90% of the population in the middle is going to be considered in the normal range, and the bottom 5 and top 5 are going to be considered out of the normal range. When you look at the raw pulmonary function testing reports, you'll see that any values above or below the limits of normal will be essentially flagged as red. Now, you may be thinking to yourself, well, if you set the limits of normal at a different percentage, so let's arbitrarily say you set it to 10% as the bottom instead of 5%. Well, exactly. The 5%, just remember, it's an arbitrary number that was chosen. Setting the lower limits at a different number will simply change the positive predictive and negative predictive value of the test itself. So as with inevitably with any disease process, there's going to be certain patients with the disease that they may not be that sick, and there's going to be people in the normal population without a particular disease that will inevitably have values in the lower limits of normal. And this graph just here emphasizes that in the shaded section here, those patients, you're going to have to use your clinical judgment on whether they may actually have airway disease or whether they're actually fine and a healthy person. When you get to the extremes of the two curves, so at the very right side, the patients with extremely healthy lungs or the patients with very diseased lungs, that's not going to be as much of an issue. It's really the center portion where you're going to have to use your best clinical judgment. So this graph here kind of explains why the changes have been made and why we're using these limits of normal to have really a much more complicated spirometry report than our prior reports. So at about age 20 to 25, everyone's lung function inevitably starts getting worse. That's just biology. There's nothing anyone can do about that. And you'll see that because of the elevated starting median value, a 20 or 25-year-old where they're in their peak pulmonary capacity, peak lung function capacity, 80% of predicted in someone, a younger patient, will actually be essentially near the lower limits of normal, maybe even a bit below lower limits of normal, versus our 80-year-old, they start out at a much lower median for baseline lung function. Their lower limit of normal is actually going to be closer to about high 60s or about 70% of predicted. So essentially, if we simply used the percent predicted, you're going to underdiagnose your younger patients while potentially overdiagnosing many of our older patients. And here, this is another graph showing FEV1 to FVC ratio over time. Again, just like with FEV1 and FVC individually, this ratio also goes down over time. So the arbitrary cutoff that we previously used of 70%, you can see that really only applies to the patients approximately age mid-30s to mid-40s. When you get to the younger patients, their lower limits of normal is supposed to be a little higher than 0.7, and similarly with older patients, their lower limits of normal for the ratio is going to be much lower. So same concept. If we use fixed values, you're going to potentially underdiagnose your younger patients with airway disease and potentially overdiagnose your older patients. And here's another chart showing how our interpretation changes. Again, just focus on the 25-year-old, either 25-year-old male or 25-year-old female, and just compare to the 80-year-old individuals. We see that in previously identified normal patients in our especially younger male population, there's going to be inevitably some that end up with using our new criteria. There's going to be some that end up being classified as having mild airway obstruction. And similarly for our older patients, choose either male or female, there's going to be many patients that were previously identified as having mild airway obstruction. They're now going to be labeled as normal based on our new criteria. So this here is where I want to emphasize importance also of not just necessarily reading the reports that we give, but using the best clinical judgment to see how you can help your patients. Now, especially in the I'm sure all of us here, we see many 80-year-olds. They're going to come. They're going to have some form of shortness of breath dyspnea. Spirometry is one excellent screening test to do the initial evaluation for these patients. With many of the patients that were, again, previously identified as having mild airway obstruction, they're going to be labeled as normal now. So for those patients, you may actually want to look at the raw data itself, take a look at the actual ratios that were that get generated from the report and decide. So yes, although we are interpreting these patients as having a normal spirometry, how normal is it actually? What is their actual ratio? Their ratio may be as low as about 63, and those patients, in the absence of any other condition that may be causing their shortness of breath, they may actually benefit from bronchodilators despite their normal spirometry that we provide on the report. And again, just remember, when we're reading these reports, we're not really chart biopsying the patients. We're not going through the notes and seeing what they were complaining about. We're not looking at their echocardiogram or cardiac data. We're just looking at a snapshot in time, snapshot of their physiology, and just know that with the difference in interpretations, you may want to look at the raw data and decide for yourself, especially for many of the now classified normal patients, whether you would like to consider a bronchodilator for treatment. This is where things do get confusing as well. I'm sure most people here are probably familiar with the GOLD guidelines. Unfortunately, the societies really haven't interacted much in coming up with a unifying way of interpreting severity. So here, the ATS criteria is indicating we're supposed to use Z-score to assess severity, but again, for the GOLD criteria, they're still using percent predicted. So this kind of puts, this does make it a little challenging in how we ultimately write the pulmonary function testing report. For simplicity purposes, I have to admit, most of the time we just go with what the GOLD criteria is recommending and still using the percent predicted. But hopefully, in the future, the ATS and the GOLD guidelines hopefully the societies will talk more and give a more unified guideline on how we're supposed to actually indicate severity on our reports, so they align more closely. That being said, most of the time, the severity of a pulmonary function test, that's not necessarily going to change your management per se. If you feel a patient is not doing well on, say, if you feel a COPD patient, for example, is not doing well clinically on a LAMA inhaler, you may want to add a LABA inhaler regardless of what what we arbitrarily write as the severity for their spirometric data. So again, you may be wondering how we came up with these limits of normal, how the population data was determined. And just for reference, in 2005 data based more on NHANES data here, over the years, essentially they just collected more data from really around the entire globe. So we're using more GLI reference equations to come up with these limits of normal for patients. So just know that the data in the current pulmonary function testing, that's going to more accurately reflect the actual population rather than the old NHANES data that we were previously using. So second question I have, moving on to just looking at our flow volume loops. I don't think this one, I don't think there's an audience response for this one. There was a software issue, but which of the following flow volume loops is most likely seen in a patient with idiopathic pulmonary fibrosis? So we'll just do 30 seconds and then we'll move on. Oh, it is working. Okay, so again, I don't think the audience response was working, but correct answer is C, idiopathic pulmonary fibrosis. We'll talk about that more pretty shortly, but that's a interstitial lung disease that causes a restrictive pattern seen in choice C. Going through the other choices, so again, this is flow volume loop. On our y-axis, we have the airflow. X-axis, we have the lung volume. This comes with every spirometry report. This is what I look at the first time I see any spirometry report. Usually, again, you look at these flow volume loops enough, you'll kind of intuitively just get a sense of the pattern, and you'll usually be able to tell what the final read is going to be before looking at the actual numbers. But this is what a normal flow volume loop looks like. The top part is the expiratory loop. Bottom part is the inspiratory loop. Comparing different patterns. Again, left side of the screen will be normal. Right side of the screen here, we see a patient with mild airway obstruction, so potentially someone with early COPD or asthma. I will say, going back to the point that I mentioned earlier about how we're changing the reads of our pulmonary function testing, I see quite a few of our older patients with FEV1 to FVC ratio, again, in the low 60s or so. That ratio will still be in the lower limits of normal, but often their flow volume loops will actually have the visual appearance of a patient with mild airway obstruction. So this is, again, if you're able to look at the actual curves themselves, they will provide you with more information than just the read that we spit out on the spirometry reports. This is someone with severe airway obstruction, pretty obvious scooping pattern, especially on the expiratory aspect. Nothing much to say here. This is going to be fairly obvious. The numbers are definitely going to reflect it in these patients. This is a restrictive pattern, so we see that the volumes are the FVC, forced vital capacity volumes, are going to be lower than someone with a normal pattern. This is a mixed disorder where you both see airway obstruction and you see the FVC is also decreased. For these patients, we often need to get lung volumes. And this is one pattern I would like you guys to kind of know as well. It is important to know this fixed airway obstruction pattern. So oftentimes you can get patients with misdiagnosis of asthma or some sort of airway disease. They frequently get treated with oral steroids. They don't really respond, you maybe get better after short ICU courses requiring intubation. Those patients may have some sort of either variable intrathoracic or extrathoracic airway obstruction where you see flattening of the inspiratory and expiratory loops. So this case in particular, you see flattening of both inspiratory and expiratory. That's fixed airway obstruction. If you had flattening only of the expiratory limb, that would be more consistent with a variable intrathoracic airway obstruction. And if you have flattening only of the inspiratory limb, that's going to be a variable extrathoracic obstruction. So just, again, this is a good example of why it can be helpful to look at the flow volume loops itself. So putting everything together, this is a good algorithm on how to think about your spirometry. Again, don't forget to look at the flow volume loops, but going through the number interpretation, we again start with the FEV1 to FVC ratio. We see if it's over the lower limits of normal, which is the 5th percentile. If it is above the lower limits of normal, and if the forced vital capacity FVC is also above the lower limits of normal, you have a normal spirometry. If the FVC is decreased in the setting of a normal ratio, it's encouraged to get lung volumes to look for possible restrictive lung disease. If you have airway obstruction where the ratio is decreased, you then again look at the FVC. If FVC is normal, then you have airflow obstruction. If FVC is not normal, then below the 5th percentile, then you may have a mixed disorder, and it's encouraged to get lung volumes. So we also have algorithm for interpretation of lung volumes. Not going to go into this too much, but essentially lung volumes can help us differentiate between the mixed disorder patients with potentially COPD-ILD overlap, and it can help identify the patients where obesity or neuromuscular weakness may be contributing to a restrictive pattern. And then just quick pearls about the diffusion capacity. A reduced DLCO is good for it's going to be uncommon to have a elevated DLCO. You may see that with asthma or shunting, but most of the time the DLCO is going to be either normal or decreased. And reduced DLCO, you want to think about pulmonary vascular disease, emphysema, again, interstitial lung disease, reduced lung volumes from prior surgeries, neuromuscular weakness, or possibly anemia. I once had a case where spirometry lung volumes were all normal, and it was just the DLCO that was severely reduced, and that person actually had severe anemia, I think in the 7 to 8 range. So it was just keep that in mind for when you look at the DLCO values. So just to end with some practical pearls, again, very important to interpret the pulmonary function testing as in the clinical context of the patient. So don't use the test itself as the end-all be-all. Use it in the clinical context of all the other data you have, including radiology and the history and physical that you obtain. Normal values will not exclude asthma and COPD for kind of reasons that I talked about. Don't diagnose asthma or COPD without having pulmonary function tests. It's common enough where you'll get patients from, they may have received their health care from a different facility. They have a long-standing history. Someone told them they had asthma or COPD. It's copy-pasted in the chart. Often, a lot of times these patients may just have something entirely differently. So it's important just to confirm the diagnosis if they're a new patient in your practice. Again, remember, look at flow volume loops. I've emphasized that enough. For the methacholine challenge, this is a test that is very sensitive to look for asthma, and oftentimes a normal methacholine challenge test, you can fairly safely exclude asthma as a possible diagnosis. So it can be a useful test to order, but importantly, do not order this test if your initial spirometry already shows airway obstruction. This can actually be a dangerous test for those patients, because what you're doing in the methacholine challenge is you're essentially trying to provoke a response where you drop their FEV1. So you don't want to do that in patients that already have airway obstruction. And it's always helpful for us to have pulmonary function testing results before a consultation visit. So, have a low threshold to just order pulmonary function testing results, and we'll be happy to see the patients and help interpret if there's ever a concern. So now moving to the second half of the talk, introduction to interstitial lung disease. Again, this is a topic that is, I think it's honestly very obscure for most patients most clinicians that are not pulmonologists. We see it perhaps in residency and medical school, and then most people don't think too much about it. So I'll give a brief overview and give you a framework about how we think of interstitial lung disease. And then I do want to introduce the idea of interstitial lung abnormalities, which I think is important just because of the prevalence of imaging that we get these days. So big picture, interstitial lung diseases, there's over 200 distinct clinical entities. We're talking about disease at the interface of the alveoli and the pulmonary vasculature, anything that impedes gas exchange, ultimately leading to dyspnea in our patients. 200 conditions, so you can probably imagine classification is important. To simplify things, I think for primary care, I would just remember the top few conditions. So we have idiopathic pulmonary fibrosis, which I'll go over in more detail, especially the radiology aspect. we have chronic hypersensitivity pneumonitis, we have connective tissue disease-related interstitial lung disease, we have sarcoidosis, we have pneumoconiosis and different workplace occupational-related interstitial lung diseases, and we have a very large other category. I think the most important one to realize in the other category is drug-induced interstitial lung diseases. So you want to think amiodarone, nitrofurantoin, chemotherapies, and especially immunotherapies these days. So when we see the patients in clinic, it's much more complex. We have to think about really all possibilities, and in between each of the categories I listed, there's multiple sub-diagnoses as well. So it's definitely an intellectually challenging condition for us to diagnose. But again, just keep this slide in mind, and you'll be correct in 90% of the cases that you see. I want to focus again on idiopathic pulmonary fibrosis because that is the most common interstitial lung disease. It's also the one with a particularly poor prognosis, and understanding kind of the framework of how we diagnose idiopathic pulmonary fibrosis will give you a good enough framework on how we think about interstitial lung diseases in general. So idiopathic pulmonary fibrosis ultimately falls under the category of idiopathic interstitial pneumonias. This is essentially the alphabet soup that you guys probably remember from residency. We have, this falls under, this entire category can be defined as a heterogeneous group of non-malignant disorders resulting from damage to lung parenchyma from either inflammation or fibrosis. So we have our chronic fibrosing, the usual interstitial pneumonia, and NSIP, non-specific interstitial pneumonia. The usual interstitial pneumonia pattern that we see correlates with the clinical diagnosis of IPF, idiopathic pulmonary fibrosis. We have acute and subacute but reversible conditions, including acute interstitial pneumonia and organizing pneumonia, smoking-related RB, interstitial lung disease, and desquamative interstitial pneumonia, and then we have our rare conditions, LIP, and pleural parenchymal fibroelastosis, which we'll kind of skip over today. But terminology is where things can get a little confusing, especially if you read our notes for these patients. So radiology and pathology use all of the terms of the alphabet soup that I just went over. They use, the radiology and pathologists will use the terms to describe the CT pattern and potentially the biopsy specimen that we request. Usual interstitial pneumonia is the pattern that correlates with idiopathic pulmonary fibrosis, but you can only make the clinical diagnosis of idiopathic pulmonary fibrosis in the correct clinical context. So for example here, you can have a patient with rheumatoid arthritis who has some sort of interstitial lung disease. You look at their CT scan, you decide that on CT scan they have a usual interstitial pneumonia pattern, but you can't say that patient has a clinical diagnosis of idiopathic pulmonary fibrosis because they have underlying rheumatoid arthritis, which is a known cause of connective tissue disease or rheumatoid arthritis-related interstitial lung disease. So this part is actually kind of important for understanding how we think of this. Similarly, a patient with rheumatoid arthritis can have either an NSIP pattern or organizing pneumonia pattern on CT scan, and those patients will still have a clinical diagnosis of rheumatoid arthritis-related interstitial lung disease, and again, not just pure cryptogenic organizing pneumonia. So important to somewhat understand the terminology here. And so when we think about these patients and when we meet these patients for the first time and we're engaged in our diagnostic workup, you can kind of think about it as we are doing everything we can to try to identify any possible etiology and any possible known condition for why the patient may have interstitial lung disease. Again, think medications that I discussed, think any occupational exposures, any organic antigen exposures for chronic hypersensitivity pneumonitis, and any underlying condition like our connective tissue diseases, rheumatoid arthritis versus scleroderma. So our history is focused on identifying those known causes. If we're unable to identify any known causes, we then use our CT imaging to look at the CT pattern, and then hopefully that itself, the CT pattern itself, plus your clinical history of having excluded other causes, hopefully that by itself can, the combination of the two can help you make the clinical diagnosis of IPF or idiopathic pulmonary fibrosis. We often get labs to look for autoimmune. We often get autoimmune labs. It's questionable whether you have to do that in all patients if you're sure that they do not have an underlying condition, but most of us will end up getting an ANA, RF, CCP, SCL70, and SSA, SSB levels to start, but you technically don't have to exclude autoimmune disease. Pulmonary function testing, as I explained earlier, you're going to see a restrictive pattern. But importantly, after you get your history and physical, after you look at the CT scan, we're going to need to decide whether we need to send the patient for a biopsy. If we're able to make a clinical diagnosis, and if we're able to say identify some sort of causative agent for the patient, we don't need to get a biopsy. If we're confident enough on our radiology study that the pattern is UIP pattern, we also don't need to get a biopsy. It's only for the cases where we can't identify any reason why the patient has interstitial lung disease, and we're not sure if the CT pattern fits with what we typically see for idiopathic pulmonary fibrosis or the UIP pattern. So it's really in those cases where we consider getting a biopsy. And then we combine all of our clinical radiology and pathology data to hopefully reach as accurate of a clinical diagnosis as possible. Often this is done in our multidisciplinary interstitial lung disease conferences where we have pathology, we have radiology, we have pulmonary, we have rheumatology. More brains are usually better than just one, and we discuss these cases in detail with each specialty, adding their input and hopefully come up with a clinical diagnosis. I do want to emphasize the importance of radiology for these patients. So X-ray is not enough. We do have to get a high-resolution CT chest. High-resolution CT chest allows for 1 to 1.25 millimeter cuts to allow best visualization up to the secondary pulmonary lobules. We often get a supine versus prone and also inspiratory expiratory cuts to look for air trapping, eliminate any effect that atelectasis could have. And when we look at the CT scans, we want to look at the pattern of disease. Is this more fibrotic versus non-fibrotic? Fibrotic with reticulations, traction bronchiectasis, architectural distortion, or is it non-fibrotic where you may see terms such as ground glass opacities or consolidations or nodularity. We also look at the distribution, both upper lobe versus lower lobe, and we also look at whether disease is more subpleural, meaning at the edges of the lung, versus more central along the parabronchovasculature. We also look at additional findings. We see if there's any effusions. We look at the esophagus to see if there's any concern for chronic aspiration. Patulous esophagus can also be commonly seen in patients with scleroderma. And we like to compare to prior CT scans to kind of get a sense of any sort of timeline of progression for these patients. So this slide here is, I think, very important. And this slide here defines what the patterns are. So how do we know based on CT imaging someone has this pattern? We can confidently say they have a clinical diagnosis of IPF. So I'm going to just focus on the UIP pattern, and we'll look at a couple examples. Okay, so the UIP pattern, usual interstitial pneumonia pattern, you're going to have subpleural disease. So at the edges of the lung, it's going to be basilar predominant, so lower lobes. distribution is going to be heterogeneous. You're going to have some areas in the lungs that look worse than others. You're going to have honeycombing, and I'll show you an example of that. And you're also going to have traction bronchiectasis. If for a patient we can see all of these factors, then clinical diagnosis is usually fairly easy to make once we've excluded all other causes of interstitial lung disease. Other patterns include a probable UIP pattern where usually these patients lack the honeycombing. They may have some more ground glass opacities. An indeterminate pattern will just have even more subtle reticulations and more ground glass features or features that are not consistent with UIP. And then other alternative diagnoses would be if the patient has a predominantly cystic pattern, mosaic attenuation, which is difference in attenuations in parts of the lung suggestive of air trapping or pulmonary vascular disease. A nodular pattern, again, will also be different than a usual interstitial pneumonia pattern. So here's a good example of a patient with UIP. So you can see here we have basilar predominant disease. We have disease in the subpleural. So again, edges of the lung is the primary part that is affected. We have relative sparing of the more central parts of the lung. And we have this very characteristic honeycombing, which is stacks of air spaces essentially on top of each other. So when we see this pattern, again, we know that the patient most likely has IPF after we've done our history and physical, excluded everything else. Contrast this to a probable UIP pattern, you'll still see more subpleural disease. You'll still see predominantly reticulations. You may see some early honeycombing along the edges, but it's not as distinct as what I showed on the prior slide. So honeycombing, again, will be definite UIP pattern, probable UIP pattern. It's not, you're just not going to be as confident as making the call for IPF. Contrasting this to an indeterminate pattern, so we still have mostly reticulations, subpleural disease, but in general, you see more ground glass. You're not going to see honeycombing. You may not see as much of the traction bronchiectasis or distortion of the airway. So in this patient, this is an indeterminate pattern. These are the types of patients where in the absence of any identified factor for interstitial lung disease, these are patients that we highly consider getting a biopsy to try to confirm whether the patient has a UIP pattern on pathology and whether we can make a clinical diagnosis of IPF. And this is a completely different pattern. So this pattern here, especially in slide C, this is an expiratory cut for the patient where essentially you're asking a patient to exhale during the scan. You see areas of distinct mosaicism or air trapping where there's a clear difference in attenuation. This pattern is, most of the time, it's going to be chronic hypersensitivity pneumonitis, and this is, again, very distinct pattern than what I showed on the previous slide for UIP. So pathology, again, it's potentially necessary in patients where you cannot make a clinical diagnosis based on your history and CT scan. We have different ways to get pathology. We have a surgical lung biopsy versus a cryo lung biopsy. We are lucky to have interventional pulmonary support, and our bias is typically to go with the cryo biopsy, less invasive, same-day procedure rather than a full surgical lung biopsy. The correlation between the two is fairly strong in the pathology data, so we often use cryo lung biopsy here. And then ultimately combining your CT pattern and histological pattern, this chart here essentially just provides guidance on whether we can make a diagnosis of IPF or not. For patients that have histologically confirmed UIP pattern, your diagnosis is almost always going to be IPF. Similarly, for patients with a UIP pattern on CT imaging, your diagnosis is almost certainly going to be IPF. It's rare that you're going to get a biopsy in someone with a CT pattern of UIP. Management is overall not great for IPF patients, unfortunately. Supportive therapies, this is where in primary care you guys can actually help quite a bit. A couple things I think to emphasize would be emphasize to these patients importance of aspiration precautions. Every visit for these patients, try to tell them go to sleep no earlier than 3 hours after dinner, so you minimize any sort of aspiration risk. Provide the vaccinations that's necessary. For symptomatic management of cough, we often consider gabapentin, and often for these patients, we do get palliative care involved. We'll kind of run through the treatments quickly. I'm running a little low on time, but we do have 2 antifibrotic medications, pirfenidone and nintedanib. They both came out approximately 2014. These medications can slow the rate of progression of fibrosis, but they do not reverse whatever fibrosis is already present. So this point should kind of intuitively make sense. You want to diagnose these patients as early as possible and consider these therapies to prevent them from getting worse. Once their lungs are fibrosed enough, you're not going to be able to fix them. So let's just go through some studies. Panther trial 2012, looking at immunosuppressive agents, prednisone, azathioprine, and N-acetylcysteine for pulmonary fibrosis. Basically, this study was not helpful. The cumulative risk of hospitalization or death was actually greater in the treatment arm. So immunosuppression not going to be helpful for the patients. That should make sense because radiographically we're seeing end-stage fibrosis. We are not seeing signs of inflammation such as ground glass changes in these patients. Pirfenidone study, again from 2014. So we see here ASCEND trial, slower rate of FVC decline in these patients over 1 year. But again, I have to emphasize these patients are still going to get worse, unfortunately, despite providing this antifibrotic medication. Second agent, also antifibrotic, nintedanib. Same kind of trial design, but patients will also continue to have a reduced FVC, but just at a slower rate than the untreated patients. Nintedanib has also been shown more to decrease the risk of acute exacerbations, which is a cause of very high mortality for these patients. We do have expanding use for nintedanib in patients with systemic sclerosis-related interstitial lung disease and progressive fibrosing interstitial lung disease, where you're not sure if they actually have IPF or not, but their disease is still progressing. So we do have expanding indications for nintedanib. And these patients often have pulmonary hypertension as well. They will be considered to have group 3 pulmonary hypertension. Previously, we did not have treatment for the pulmonary hypertension component specifically, but now we do have inhaled pulmonary vasodilators that can be helpful for these patients. So this increased trial looked at inhaled treprostinil, and we see that over about a 4-month span, the patients that were treated have a improved 6-minute walk time from the baseline. Overall, I just have to emphasize these medications are very limited in what they can actually do for the patients. Slow progression, maybe may improve their 6-minute walk in the select population, but they come with fairly significant side effects: diarrhea, nausea, photosensitivity in patients with pirfenidone, and the utility is still very limited in patients with advanced disease. So ultimately, if we feel like these patients are a transplant candidate and they've been tried on medication, they continue to get worse, we talk to our transplant centers. Both single lung and double lung transplants can be done for these patients. Just to note, lung transplant patients do not do as well as patients with other organ transplants. Typical mean survival is about 6 years, so still not great, but much better than just the anti-fibrotic agents that we have at the moment. Prognosis, about 3 to 5 year mean survival, and definitely prognosis increases with acute exacerbations. So for the last few minutes that I have, I want to introduce this idea of interstitial lung abnormalities, and this is one area where I think primary care can potentially help us identify these patients earlier. And hopefully with the slides that I just showed, I kind of painted a pretty grim picture for these patients. And really their only kind of hope is early identification, potentially initiation of an anti-fibrotic agent early in the disease so they can preserve their lung function as much as possible. So this is a paper that came out from the Fleischner Society. You guys probably know the Fleischner Society from the evaluation of lung nodules. So same thoracic radiology society that provided guidelines on what we do for lung nodules. Key point for looking at lung nodules is we want to ensure that the nodule does not become cancerous. Same big idea here. Any sort of interstitial abnormality that you may see on some sort of CT imaging, we want to make sure these patients are not at risk of progression to IPF. So guidelines here are not going to be as robust and clearly defined as our lung nodule guidelines, where the Fleischner papers essentially tell you what to do for, nodule size, nodule location, smoker or non-smoker, get a scan in 6 months. So guidelines here are not as defined and precise, but this is a good start, and this is a new concept that is still being worked up between pulmonologists and radiologists. So what is an interstitial lung abnormality? This is an incidental identification of a non-dependent abnormality, including ground glass changes, reticular abnormalities, lung distortion, traction bronchiectasis, honeycombing, and non-emphysema cysts involving 5% of the lung. And again, we all get radiology, we all get CT imaging very frequently for our patients. You guys get cardiac CTs fairly regularly. Our patients are enrolled in lung cancer screening, so that's another study. Urgent cares, we get CT angiograms regularly, and also it is important to note the CT abdomen and pelvis. Even though your intention is not to look at the lungs, you do get a good portion of the lung that is actually visualized. So there's a lot of opportunity to look at the lung in patients that you're not necessarily suspecting any sort of underlying interstitial lung disease. So again, goal here, identify the patients at risk for progressive interstitial lung disease who may benefit from earlier evaluation and treatment. Kind of skip over some of these slides, but subcategories, we have 3 non-subpleural, we have subpleural non-fibrotic, and we have subpleural fibrotic, and it's really the third one, the subpleural fibrotic patients, similar to, again, the UIP pattern on CT imaging. Those are patients that we really want to identify, and we may need to do more investigational work. This here is example. So just focus on panel C. We see that panel C, this patient has some reticulations in the base of the lung, also some signs of traction bronchiectasis with the enlarged airway here. So again, is those patients that you see where radiology may provide some of those keywords, those are patients that you want to think about that may progress to having clinically significant interstitial lung disease. So this is just an example of disease progression over, I think, about a 4-year span. So this here subpleural reticulations, over the years, we see that much more noticeable early development of honeycombing. There's just a couple other examples that we'll skip over. But in terms of the workup for these patients, no major consensus at this point, but I think the takeaway home, again, is just to try to identify those patients, even if you're not necessarily looking for interstitial lung disease. Try to identify those patients with the subpleural fibrotic pattern. Look for the buzzwords in the radiology report. They will always indicate how the lung looks itself. Look for those buzzwords. And in my opinion, those patients, if you do identify them, not every pulmonologist is going to necessarily agree with me because, again, from our end, the guidelines are still questionable in how often we should follow up with these patients. But in my opinion, I think these patients, if you're at all concerned with a subpleural fibrotic pattern, I think these patients warrant an evaluation in pulmonary clinic. I personally will be happy to see them do a full ILD assessment and help decide if these patients have ILD, subclinical ILD, or whether this is just an abnormality that we can follow, similar to us following a lung nodule that is concerning. So takeaway points, we talked about the new PFT guidelines. Remember to correlate the clinical data with the physiologic pattern. Hopefully I gave an overview for interstitial lung disease and how to think about diagnosis of IPF and consider early referral in patients with interstitial lung abnormalities, which is a new concept in our literature. And that's it. Open any questions if you guys would like.